13 Hours, the story about Benghazi. And as you're watching that movie, it's like, oh wow. I mean, it was a perfect storm. There couldn't have been anything possibly worse that could have happened to those folks. And so you just want to, I was in on the conversation with, the most recent one was the one at the University of Maryland, which was heat. But still, there were opportunities for those folks to have stepped back and looked at it and realized this is really trouble. Instead, it was about an hour and a half before they really got serious about taking care of that athlete. So, just a warning. Don't procrastinate. Laziness pays off right now. So I touched on this in the introduction. You want a proper diagnosis. So asthma is really common, and so it happens commonly. But there are other things that can kind of cause people to get short of breath. The most dangerous one being the heart. If your heart's not pumping and not working right, or going into some kind of crazy rhythm, then you can get symptoms that look very, very similar to asthma. So you really want to think about making the right diagnosis. There's been more than one study that's looked at if an athlete tells you they have symptoms with these types of exercises, it is notoriously poor for making the diagnosis. So even if you have an athlete that hits every checkbox, it may not be asthma. And if you have a kid that doesn't mark any of the boxes, they still may have asthma. So it goes both ways. So you can't just use symptoms, checklists, and that kind of stuff. You have to get them in to the lab. You've got to challenge them with exercise or some sort of chemical to kind of test for this. Because there was so much use of inhalers, beta blockers, and this kind of thing in the Olympics, the International Olympic Committee forced athletes to get this kind of testing done before they could get a therapeutic exemption. And so high-level athletes have to go through this. Now, with high school athletes and even college athletes, they don't require a therapeutic exemption. It's just at the Olympic level, at least for now. But the test that you're doing, the FEV, is forced expiratory volume in the first second. So these pulmonary function tests, I'll show you a picture in a minute, they measure how much volume you can get out in the first second of your expiration. And if that drops below about 15% of your best, or what would be expected to be your best based on the data that we have for that age, that size athlete, that kind of thing, then that's a positive test. So if you do a forced expiratory volume, that's your 100%. Then we put you on the treadmill, or we put you out and run you around. We have you do your sport, and then we immediately test you again. If it drops more than 15%, then you've got exercise as a trigger for your asthma or your bronchospasm. And different governing bodies require different kind of documentation. So at your high school level, you don't have to worry about this too much. But at the college level, a lot of these college athletes are running for their home country. And so knowing what they can take and what they can't take and what documentation you need, because they're going to leave your college and go back to their home country and run and maybe get tested. So all these are things that you need to consider. So I'm not sure that this shows up real well, but this is just a fairly recent description of kind of where you sit. are you down here at step 1 where your asthma is pretty well controlled? It only happens every once in a while. You don't get a lot of symptoms very often. And then, your lung function is about 80%. And then moving up all the way to severe and persistent. And these are ways of kind of grading asthma as a disease. And each one of those, you see that's not really up here. It takes more and more types of medications and more interventions to get these people to where you can actually take a severe persistent and move them all the way down into this mild intermittent with the proper kind of care. Again, that's going to be taking place at the level of probably a pulmonologist or an allergist immunologist, not even a primary care physician. So I'm going to show you these challenge tests. There's one test called a methacholine test where you get the test and then you get a breath of something called methacholine, and it tests for how sensitive the bronchioles are to these triggers. How hypersensitive are they? And then there's a couple other tests that I don't even understand all that well. A Eucapnic hyperventilation test and an exercise test. But all of these tests, you're better off actually using the equipment that is used for a full-blown pulmonary function test. Some of you guys may have seen well, I'll show you a picture in just a second. So this is kind of what you expect to see in a pulmonary lab. And so you're going to blow into this here. Does it show up here? No, that doesn't show up. There's a mouthpiece right here that you blow into, and this contraption and the computer measure how much volume you've got. But another piece of equipment that a lot of these kids who have asthma will have a peak flow meter. And the peak flow meter is not great for diagnosing it, but a peak flow meter can be really good if you have an athlete who is used to using it and they feel like they're getting a little bit symptomatic. Then you can pull out the peak flow meter and you can test it and you can kind of see if you don't have a pulse ox. But this is just a way of kind of a quick and dirty, but it's not real helpful with regards to making the diagnosis. So some things that can be recommended to these folks that are not medications. You can run with a mask and it can help make the air warmer. You can have them work at and try to nose breathe as much as possible. And then if the air quality is bad, you don't exercise that day. You wait for the air quality to get better. As they get in better shape, a lot of times these symptoms will get better. And then we talked about this refractory period. And some of these athletes can get very good at learning how hard they have to go for 6 to 8 minutes and then compete in their activity, within the next couple of hours. And they can actually get very, very good at this and make that part of their routine so that they don't get symptomatic during their competition. So I tried to kind of break these down into groups. The ones that you guys are going to see the most as far as a medication is going to be albuterol. And that's called a beta-2 agonist. And they come in long-acting and they come in short-acting. The short-acting you can use as a rescue medication. They have symptoms and you want to try to avert their symptoms. That's the albuterol inhaler. There's not really anything else that you can use as a rescue medication. Everything else, you can get it with the anticholinergics, the ipratropium. You can use that as a rescue as well. But all the others are being prescribed by their physician for them to take on a regular basis so that they stay at that low level. Don't try to use a long-acting beta agonist or cromolyn to try to avert an acute respiratory kind of problem. Okay, it's just for the most part, it's just the albuterol that's going to do that. But if you have a kid that kind of has exercise-induced asthma and they're playing baseball and they're going to play a weekend tournament, they may only have to take a couple of hits on their long-acting beta agonist first thing in the morning, and that's going to be enough to hold them for the entire day. Okay. The other really big intervention is actually down here at the corticosteroid. About 20 years ago, a big change happened in asthma about this inflammatory kind of thing. And there was also some studies that showed chronic use of a steroid inhaler didn't have all the baggage that you get from taking oral steroids, okay? And so because of those two things, really, if somebody has asthma, underlying asthma, they're going to be on a regular dose of a corticosteroid. And we don't worry about that cortisone kind of affecting their body kind of systemically like you do if you take it orally. Now, sometimes you'll have kids that when they're in the middle of kind of a bad kind of flare, they'll take the oral corticosteroid for about a week at a time, just to kind of get all the inflammation down, kind of knock it out. And then there's some of these, like the bottom one, the leukotriene antagonists. They can be used, and they seem to help with exercise as a trigger a little bit better than some of the others. So the pulmonologist, the allergy immunologist is going to know these kind of things and kind of figure out a cocktail that's going to work well for these athletes. What you guys basically need to know is just what I told you. And then there's some others that are kind of off the norm or have been around for a long time. Theophylline, calcium channel blockers, even antihistamines, if there's a big component to their allergies as being a trigger. So this is kind of a busy slide, but it just kind of takes you through. You have an athlete that has some symptoms that are suggestive of bronchospasm. You're going to want to get a diagnosis. And if they don't really test out the way that they should, if they're asthma, then you really need to be thinking about this may be something else. But if it is asthma and it's confirmed, then you try these non-pharmacologic interventions that we talked about. But if they need some medication, you kind of go down this other route, and that would be, of course, a route that you're not going to need to deal with, but it's good to be familiar with. So this is some of the more recent recommendations. So you got an athlete who's sucking wind, and you know that they have asthma. What's the most common cause for that athlete to be having trouble breathing? What would you think? Air quality, illness. What do you think is the most likely cause that this athlete is having trouble breathing? Nobody's got a guess? Out of shape. Out of shape? Thought? So it's non-compliance. They're just not taking their medicine. That's the most, especially high school kids. I mean, come on. But even anybody, not just the high school kids. And you know, that's where you as an athletic trainer may have to just bear down on these people. They got parents at home, but sometimes they need somebody who's going to be an adult in their lives at practice and play and that kind of stuff. So treat it really, really seriously. I mean, nobody likes to be the nag, but in this case, there may be